Then when you progress to stage 2, it says if the patient had an inadequate response to an antipsychotic drug in stage 1. So the question then becomes, how do you know this, right? Well, typically what you have in treating patients with these drugs, you titrate them up to a good dose. You start at low, go up every few days, okay? You hit about midway to 2/3 of their max dose, which will show you the max dose range in a minute or two. Then you balance that versus side effect. If there's a smidging of improvement, which we'll talk about when you see the acute versus stabilization, you keep going until you have side effects. This is where the art versus the science of drug that comes in, okay? And then, of course, when the side effects become too much, or when you get to the max dose and you're still not getting the clinicians feel that they're getting the full benefit, then they'll switch the drug. And then, of course, how you switch the drug becomes another process, okay? So that's stage 2. Then you could see if you want to switch them, you could switch them to any other antipsychotic drug, all right? Except clozapine. We're getting back to that again, same box. Excuse me. And then when you get to stage 3, then they said you've tried at least two different agents. Then one could consider another agent, or now then consider clozapine. And it's clozapine monotherapy recommended, okay? So that just takes you through this step. But you notice here you've got this box on the other side. Depending upon the patient, either at stage 2 or stage 4, one could consider a long-acting agent, meaning like they did respond to their medication, but they just don't like taking oral drug every day. Who likes taking oral drug every day? We have products that will give you like an injection once a month or once every 3 months. Okay, that may be a therapeutic option for them, depending where they fit in the algorithm, okay? And then the last stage 4 says minimal evidence exists for treatment option for patients who have not received adequate treatment response, even with clozapine. So even if you have tried them with clozapine, not all patients respond. We'll show you actually a clinical trial that demonstrates that. So then the question is, what do you do? That's a tough question. You're going to see that a lot in many chronic patients, especially with 20, 30, 40 years of schizophrenia. You'll see them on a lot of antipsychotic drugs. When I say a lot, you know, we have classically taught you to try one drug at a time, right? You take it up, but you see with anti-epileptics, you see combinations, right? But based on different pharmacologic profile. Well, when I was in school way back when, we were taught to use only one drug. But gradually, since the advent of the atypicals, real world starts creeping back in. You're going to see people on at least 2 atypicals. Whether that's right or wrong, no one's still, that jury's still out. It just hasn't been studied. The FDA can't say anything about that because nobody studies it, okay? But that's what you may see. You may see someone on an oral antipsychotic drug, a long-acting drug, a mood stabilizer, and an antidepressant. Okay, so those are things that when you're down to box 4, you're really, that's really an art. Or maybe you're flying by the seat of your pants. I don't know. Those are things you think about, okay? And again, as I mentioned maybe earlier in class, that in some of my earlier work, we had patients on as many as 14 psychotropic medications at one time. You just don't know what the heck you're doing, in that aspect, okay? All right. So that gets my question, how do you choose? Well, first generation, it says when they were developed, persistent positive symptoms, okay? And it just depends also on formulation. And of course, if they have uncontrolled diabetes, that is probably, you might want to consider that, but there are a lot better second generation. So very rarely people now use first off the bat, first generation. Your second generation certainly are your more desired agents, and then you have to look at the patient's side effect profile. Like, for example, if they have previous history of EPS and tardive dyskinesia, then you have to think about that. And then you have to look about, you talk about obesity, weight gain from these agents. This is one of the really unfortunate or interesting developments we've had with second generation antipsychotics. So we have a few agents that really have a low metabolic risk. So if you have a type 2 diabetic patient and there's a high prevalence of patients with schizophrenia, because about 3 out of every 4 patients with schizophrenia smoke, about 2 out of every 3 schizophrenic patients also have diabetes because they don't manage their diet, because they don't really care about their diet. They're in their own little world of thinking, that kind of stuff. So those are things you have going on in that. So you have to really try to manage those difficult patients. Okay, so you see how you try to match the drug with the patient. And then here, your long-acting injections. Obviously, a patient has to be agreeable to taking shots. You have to ask them. All right, non-adherence, and then here's some of your options, and we'll talk more about that. So here's your dose range that's in your textbook. And there are a couple things to point out. One, these drugs are very safe. Even though they're antipsychotic drugs, they got a lot of side effects. These are your suggested max dose. So let's take the first one, chlorpromazine. It says max dose of 1,000 milligrams. By the way, that's a lot. But the clinical trial that brought clozapine its FDA approval, that clinical trial allowed 1,800 milligrams to be treated. You had to be treated with 1,800 milligrams, almost twice that. Whoa! Okay? Patients still walked around. We'll show you the side effect profile of that trial. You take another commonly used first-generation agent, haloperidol, good old Haldol. Your textbook says 2 to 20 milligrams, okay? When I was in school, way back when, and when you look at the clozapine clinical trial, to be considered treatment resistant, you had to go to 60 milligrams of Haldol, haloperidol, 3 times that dose, and people were fine. Whoa! So today, no one uses these high doses, or at least shouldn't, okay? Because you get a lot of side effects, right? I once had a psychiatrist, as I mentioned in Memphis, you know, he would start out a patient on haloperidol, 20 milligrams a day. If they were still uncontrolled, he'd double the dose the next day and double the dose again. He'd go up to 80 milligrams by week 1. Yo! And he said, what's the worst thing that could happen to them? They get a little EPS. I could treat the EPS, but they're not going to harm anybody. So you just kind of go, you scratch your head. So again, that gets back to the art versus the science. When you go on rotation today, you're not going to see these high doses. People have started to bring them down. Okay? Now one could argue that's why you have to use more than one agent sometimes. Okay? So it's a balancing act. Some of these have a guaranteed high max dose. I mean, it's fixed. When it says max dose, like for example, we have thiaridazine. You see here significant QTc prolongation, but also has retinopathy. So at higher doses, it causes really bad things. So thiaridazine has a hard, fast 800 milligrams. And I'll bring that out as we talk about some of these individual agents, okay? And then here you have your other atypicals. You've got some notes about dosing and slow metabolizers. Clozapine, our friend, check plasma concentration when you get past 600 milligrams. All that sort of stuff, I would say, is important to note, okay? Now, I'd also like to point out that we have one agent, acenapine, that you can take sublingually. If a person takes this pill and swallows it, it's got like an 8% bioavailability. If it's sublingual, it's like 40%. Really interesting aspect with that product. The key thing is to try to talk a psychotic patient to take a pill and leave it underneath their tongue. I've tried that. Sometimes it doesn't quite work. And then you say, why did this drug not work? Well, not enough got in their body, right? They swallowed it. So anyway. And then you could see here a couple drugs like the prazodone and paliperidone. The bioavailability increases when taken with food. So you ask them to take it with a meal. And it really increases by a good 30%. So that's why they do that, okay? So you've got a couple products that you really have to take with food. And then you have one product, I'll bounce up here for a second, loxapine inhaled. You see it's a maximum of 10 milligrams for 24 hours. That's hard and fast, and it's approved by REMS only, another risk management. And the reason for that is that it's a special formulation that when you put the person's mouth, it's like an inhaler, but it's a one-dose inhaler. You squish it down, you get 10 milligrams of loxapine. It's supposedly used for emergency department in patients who don't want to take an oral drug or a shot. I don't know its success, but it's certainly available and on the market. Okay, so let's talk about one of the newer drugs, bromipixol Rexulti. It is structurally like aripiprazole. This is your doses. The recommended dose is 2 to 4 milligrams per day. This is a typical starting pattern. It is heavily metabolized by CYP2D6 and 3A4, so you have to really make a very large dosage adjustment. So again, keeping in mind for potential drug-drug interactions, which we'll talk about like with SSRIs or other drugs, okay? Keeping in mind you've got poor metabolizers. You can see it's got a long half-life and really goes with once-a-day dosing. These are the 2 phase 3 clinical trials that brought this drug to market. You're probably saying, why did I put this slide in there? Because we're going to talk about this drug trial, okay? The FDA regulation, you need 2 positive clinical trials to submit to the FDA, okay? Give you a hint. This clinical trial, this is the one that you're going to see this afternoon for Journal Club. So, heads up, all right? So, what does this trial look like? And the trials are very similar, almost cookie cutter for the FDA, okay? Obviously, double-blind, placebo control, all those wonderful things.